Hi, I'm Kelly Braun, and this is my and my group's presentation on quality indicators. So what are quality indicators and why are they important? Healthcare organizations track a wide range of quality indicators to enhance patient outcomes, reduce healthcare costs, improve quality of care, and promote greater access to care. In the primary care setting, these indicators commonly focus on cancer screening, such as cervical, colorectal, and breast cancer, as well as managing chronic conditions like hypertension and diabetes, among others. Lots of specialty clinics have more specific indicators that they focus on.
So here are the cervical cancer screening guidelines according to ACOG. So notice here we don't screen anybody that's under the age of 21. Once a patient turns 21 through 29, we recommend pap smears every 3 years as long as results are normal. Once a patient turns 30 through 65, we recommend HPV co-testing with the pap smear every 5 years as long as that's normal. And then once a patient turns 65, we don't recommend screening if they've had previously negative results. But risk factors that could increase screening frequency would be a positive HPV infection.
So what is cervical cancer screening? Well, as she discussed, it involves a pap smear, which involves cervical cytology. It examines cervical cells for abnormalities. It also can involve HPV testing, which looks for high-risk types of the HPV virus that can lead to cancer. And it's important because it identifies precancerous or cancerous changes in the cervical cells. And cervical cells typically take 3 to 7 years to develop into a cancer. So if the screening is done as recommended, it will detect it in its early stages, allowing for early intervention and better outcomes.
So this is the cervical cancer screening measurements that we look at with the quality indicators. So we're specifically measuring the percentage of women 21 through 64 years of age who were screened for cervical cancer according to the recommended guidelines. Our rationale is because with routine screening with the pap smears, we can prevent cervical cancer by the early detection of the abnormal cells, like Kelly mentioned. And a clinical example where this would apply would be a 24-year-old female who presents to the clinic for an annual physical. So we're focusing in on those care gaps and making sure that she's up to date on her pap smear. So next, we'll talk about colon cancer screening guidelines, and that's according to the U.S. Preventative Services Task Force. So routine screening begins at 45 and it continues through 75 years old. The screening frequency is based on the patient's risk and the type of test that's done. So risk factors that can increase screening frequency includes any irritable bowel disease, such as colon cancer or ulcerative colitis, a family or personal history of colon cancer, and then a personal history of polyps. So the different screening options, we have colonoscopy, which is the gold standard screening test. And if that's normal, it can be done every 10 years. We've got the fecal immunochemical test, also known as the FIT test, and that looks for blood and stool. And if that's normal, it can be done yearly. We also have the FIT DNA test, also known as the Cologuard. If that's normal, it can be done every 3 years, and that looks for abnormal DNA in the stool. And then we have the flexible sigmoidoscopy, which only looks at a portion of the colon. And if that's normal, that can be done every 5 years.
So to discuss colon cancer screening more specifically, as Carlie discussed, it involves colonoscopy, which is the gold standard. That one directly visualizes the rectum and the entire colon. And if polyps are seen, they can be removed right then and there during the test. It also involves the different types of stool tests, such as the FIT or the Cologuard, and that detects blood or DNA in the stool. If that is abnormal, then it would prompt the patient to get a colonoscopy to get the areas removed. There's also a flexible sigmoidoscopy, which directly visualizes the rectum and 1/3 of the colon, the lower colon. There's always new screening options coming onto the market, but these are kind of the more common ones that have been around for a while. And these matter because they detect precancerous or cancerous changes in cells, allowing for early removal and treatment. And patients are often asymptomatic when they have precancerous or cancerous changes in their colon or rectum. And so early detection is important to allow for early treatment and better patient outcomes.
So for colon cancer screening, the specific measurements that we pay attention to is the percentage of adults who are 45 to 75 years of age, who've had screening for colon cancer done according to the guideline recommendations. The rationale for this is that colon cancer is the second leading cause of cancer-related death in the United States. And with early detection, colon cancer has a 90% survival rate, so we want to make sure we know about it if it's there. A clinical example is a 65-year-old male who presents to the clinic for a Medicare annual wellness visit. So again, we're addressing those care gaps, making sure he's up to date on all of his cancer screenings.
So this is an actual target and results from the cervical cancer and colon cancer screening rates at one of our family medicine clinics. So this table above shows the target goal and then the actual completion rate for cervical and colorectal cancer screenings from July of 2024 to April of 2025 at one of the family medicine clinics where one of us completed our clinical rotation. So as you can see, they weren't quite at target, but they were pretty close, which is pretty good.
Okay, and incorporating quality indicators into clinical care and the challenges associated with integrating them into practice. I did a case study from a specialty practice perspective at the Rural Sports Medicine and Orthopedic Center. Due to their high patient volume, they are frequently asked to integrate quality initiatives such as implementing quality indicators into their practice and adjusting workflow to screen for issues the department typically doesn't manage was a significant challenge. The department had to develop protocols for handling a positive screen when none existed before, and during this process, efficiency was significantly hindered due to the absence of an established process for the next steps following a positive screen. Investigators tried to identify an appropriate workflow for specialty clinics, placing workflow in clinic rooms for easy reference. Education to the staff was given, and as well as providers, including additional training on referral workflow for positive results found with the PHQ2 and PHQ9 and Columbia screening tools. Recognizing that depression is a serious medical illness associated with higher rates of chronic disease, increased healthcare utilization, and impaired functioning, most of the patients treated at the Sports Medicine and Orthopedic Center are treated because they're in pain, and their mental health can be affected by their pain and condition. The initiative included a 9-month depression screening, as well as a breast cancer screening that is still ongoing. And for that specific depression screening, the goal was to improve the screening rate to at least 50%, and they actually achieved 70% screening during the 9-month process. But challenges specific to this initiative included understanding that specialty providers are not always equipped to address specific mental health issues or screening for breast and colon or cervical cancers, since it's not typically part of their workflow. More challenges include workflow adjustments. Healthcare professionals often find the additional documentation required for quality indicators time-consuming, detracting from patient care. Further aligning clinical workflows with quality metrics can disrupt established routines, causing resistance among staff. Engaging staff in the training or limited training on reporting requirements on quality indicator methodologies hinders implementation efforts, and resistance often arises when staff perceive new initiatives as added workflow without clear, tangible benefits. And then there's some other barriers as far as regulatory and administrative barriers, including frequent changes to reporting requirements that can contribute to confusion and are compounded by tight schedules and limited staff resources. Strategies for successful integration from this specific project and probably applied to others, is including enhancing staff training and engagement by fostering a culture of continuous improvement by actively involving the staff in planning phases and offering ongoing education on the UADS requirements and QI methodologies. A major component of enhancing staff engagement is in understanding the rationale. Like, why are we doing these things? Why is it important? Each week during these initiatives, the department would meet with the employees and discuss what had been working and what hadn't, making sure their input was valid. By addressing these challenges with targeted strategies, healthcare organizations, including this one, can potentially successfully integrate reporting on quality indicators into clinical care, ultimately improving patient outcomes while fostering a culture of continuous improvement. They also utilize the continuous feedback loops, which we're holding regular team meetings to discuss the challenges and refine the process based off of staff input. This helped build trust among clinicians and staff. And future goals were to improve the identification process for overdue screenings, questionnaire delivery, and documentation. This was to decrease patient frustrations, increase collaboration with patient access teams, and expand the screening process to include future colon cancer and other quality indicators following the end of their breast cancer screening initiative.
Back to provider compensation and how this plays a role. So we all talked to our preceptors in our clinical sites, and we found that some of our clinical sites did incorporate quality indicators into provider compensation, while some did not. Of the ones that did, many of the preceptors weren't quite sure, though, the specifics of how this was calculated into their base and/or bonus pay. They just knew it was affected by it. And then of the ones that did not, their pay was just like a flat salary rate, and they didn't have any bonus or RVU potential. Not to say that quality indicators weren't important to them, it just didn't affect their pay. In general, however, quality indicators are increasingly incorporated into both provider evaluations and compensation systems within healthcare across the country. And so AMN actually did a 2021 review of physician and APP recruiting incentives, and they found that quality determines about 10% of the total compensation a provider receives. So that's a pretty big deal. So compensation for meeting QI goals seems to be fairly common, but fairly common especially in family practice. So it's something that we have to think about. In conclusion, quality indicators are routinely used in healthcare, but especially in primary care, to monitor and promote better patient outcomes. Quality indicators serve as a framework for delivering evidence-based care. Quality indicators support preventative care strategies, especially in cancer detection and chronic disease control. Like we talked about, proper use of cervical cancer and colorectal cancer screenings can significantly improve early diagnosis and patient outcomes. And then understanding these screening guidelines and then, patient-specific risk stratification is essential to tailoring care for individual patients' needs. And then in general, there's this systemic push to tie compensation and evaluations to quality outcomes, but especially for family practice. So anticipated challenges in our future clinical practice, looking at all of this, is just like balancing guidelines with those patient-specific variables, how QI initiatives could disrupt workflow and the increasing documentation burden that comes with this, staff engagement and buy-in, administrative and scheduling barriers, and then just confusion around compensation and how it all happens. So now that we know all this, some of the future goals for our practice as we're all kind of transitioning into this NP role upon graduation is to explore compensation models more deeply and advocate for clarity and fairness where quality indicators affect pay. And then we all aim to practice in a setting that values quality-driven care backed by proper support, resources, and transparency. So hopefully as we make this transition, it'll be a good one. And then here are our references. Thanks for listening.